just before the coffee break that made us fly very high in the sky. We go back to the reality, but I'm pretty sure that this session will be fantastic because it's an embryology session. And as you know, it's the best job in the world. Okay, so we are really anxious to listen to all of you. Don't be that nervous, Alessandra, because I see you shrinking. No, now I'm going to pass the mic to Daniela, please.
Good afternoon, everybody. Welcome again. It's time to start, and it's my greatest pleasure to invite to the podium Dr. Nathalie Vermeulen. She's a research specialist. She initiated and developed the ESHRE guideline program. She has now been appointed as Deputy Managing Director. And her topic will be the ESHRE Good Practice Recommendation and Guideline Framework. Please, Nathalie.
Thank you. Thank you for having me in Bologna, and thank you for the nice introduction. So I will present you the ESHRE Good Practice Recommendations and Guidelines Framework. So, quick layout of my talk. We have a house rule in our house, and that's a 1 hour screen time rule. And I have these two little boys, beautiful guys, and they challenged me. They said, why do we have this rule? My friend, he has a 4 hour rule. We would like that rule as well. So why do we have this rule? I was having a whole explanation to them about what I consider good parenting and my experience and what I think is healthy. But in the end, I gave up and I told them, bring me some data and then we can have a consensus on this 1 hour gaming rule. And actually, that's also what happened in how evidence-based medicine came about. Decisions were made based on the expertise of the senior clinician, based on what was in textbooks, based on what commercial companies said. And at some point during the 80s, it came to people's minds saying, we need good arguments, we need the scientific data that are out there to base our decisions on. The term evidence-based medicine was first published in 1996, and after that it was refined to its current definition, which is actually that it's a healthcare system where treatment decisions are made based on the best available knowledge, clinical expertise, and then patient preferences and expectations. Now, if you want to do evidence-based medicine in practice or evidence-based practice, you go with a question, which can be a clinical question, but also a question in the lab. And you try to find the best available evidence. And how do you do that is you define a PICO question, you define your patients, or if it's about oocytes, you can use oocytes for that as well. You define your intervention, what you want to do with your patient, option A versus option B, the same actually in the lab, an outcome. And then you use these information to go to PubMed, perform a literature search, you get some papers, you assess them, you make a meta-analysis, and then you have the best available knowledge and you apply that. Just a random example, if you want to do that for this specific question, which is on endometriosis, you would end up with 3,000 references to screen, you end up with 160 full-text papers to read, and in the end you have 9 papers to base your decision on, which is quite a task and not really something people would do in daily life. This whole process is facilitated by reviews, which actually combine already this best available knowledge for you. And we as guideline developers go one step further. We integrate also the clinical expertise and patient preferences, and we do actually the work for you. Of course, this system only works if you do it in a way that's trustworthy and people trust what you are writing in your guidelines. So you need a structured and standardized methodology. We have a manual. It's quite a big document for anyone interested, and it defines the 12 steps we use to develop our guidelines. And I'll run you through highlighting some of the most important steps. This manual didn't come out of thin air. It's based on 2 established guideline development systems. One is the GRADE system, which is used to grade the certainty of evidence and the strength of recommendations, and also how to go from your evidence to your recommendations. So there are different systems for that. And the other system is the AGREE system, which is actually a quality checklist for guidelines, stating what should be included in guidelines and how to make sure that whatever you present is transparent and usable by whomever uses your guideline. So after we define a topic, we compose a group of experts. Not only experts, we also include allied health professionals, which are nurses, psychologists, ethicists, whatever is relevant for the topic at hand. And we try to balance expertise, location throughout Europe, people working in private centers, public centers, and we also try to include patient representative in our guideline groups. They all have to declare conflict of interest to make sure that it's transparent again. And then they define the scope of the guideline, what will be included, what will not be included. They define a number of key questions, which will be the backbone of your guideline in the end. And then we go on to finding the best available knowledge. Similar as I explained before, we go to PubMed. That's something that me and my colleagues at the central office do for these guideline groups. And we focus on peer-reviewed publications. And then the difficult part starts, which is to go from the papers you have collected to the ones you really want to base your decision on. First, you check whether, in fact, the papers are relevant for your question at hand, whether it fits, whether they have the same patient group, for instance. And then you check the quality. You check whether you're confident, whether you trust the results presented in these different studies. And you do that by doing a quality assessment. Basically, and this can be a 2-hour presentation on itself, but basically this is an example of an RCT. And your quality assessment is to check every single step of this RCT, whether it's appropriately done, and whether if there is something wrong, it would have influenced your results and conclusion. If you're satisfied with the different studies you have at hand, you would combine them into a body of evidence which will guide your clinical decision. To do that, you can combine all the evidence in evidence tables, with also these summary of findings tables, which are probably very familiar from Cochrane reviews, and they list a certainty of evidence. And this is something that's very difficult for people to understand what it means and how people come about this certainty of evidence. And actually, it gives you per outcome, because that's how we work, per outcome, it gives you an estimation of how much trust you have in the results. If you grade something as very high, you're quite confident that whatever the study is saying is the true effect that exists. If you grade something very low, you're not that confident, and probably if there are more studies in 5 years, there might be another result, or there might be the same result, but you're just not confident. To establish this certainty of evidence, you look at the individual studies you have included. For each of them, you have checked whether they are good quality, bad quality, what are their weaknesses. So this is your risk of bias. But you also take into consideration whether all these different studies actually say the same thing, whether they all say that treatment A is better than treatment B, or whether there's some inconsistency between them. You also assess whether there is indirectness. Are these studies really looking at the same population as you are in your key question, or is it a bit different? Are the patients a bit older, are the patients a bit younger? These kinds of things. You look at the confidence intervals and you assess imprecision and then publication bias. In theory, whenever your decision is based on randomized controlled trials, you would say this is high quality evidence. But because of all these different risks and assessments you make, you could reduce this quality of evidence to a lower level and say, well, actually, I do have 10 RCTs, but they're saying different things. So in the end, I'm not that confident anymore that I know what the answer is. In the other way around, if you have a bunch of observational studies, by definition they are low quality. But then if you have a lot of observational studies all saying the same thing with a dose response, you could say, well, this increases my trust in the conclusion. And this is just to put it a bit more easy. So RCTs, by definition, are high certainty of evidence. But if you detect, for instance, in a number of them some risk of bias, you would downgrade to moderate quality of evidence. And then if you, for instance, also have some inconsistency between your studies, your conclusion would be that you have low certainty in this specific question at hand and answer at hand. This is what we see in the reviews. This is where reviews also end. So they say we have moderate quality evidence or we have high quality evidence, but that's where it stops. In guidelines, you have another step, which is the recommendations, which is the time when you bring together the knowledge you have collected with the clinical expertise and the patient preferences. Again, there's a whole framework to do so, but it comes down to judging what is the evidence saying, how strong is the evidence, what is the quality of this evidence, what are the benefits and the harms of the different interventions at hand, and how do they weigh up against each other, and what are the values of both the clinicians and the patients. You could also take into consideration the context, which is resources and health system perspectives, which is not something we do all the time, but then some interventions may be very good, but not available in Europe, and then doesn't really make sense to recommend them. Based on this whole analysis, the group actually decides to go for a strong recommendation or a weak recommendation. As I told you, this is weighing up all the different factors. There's no +1 in this. This is a judgment of all the different factors. And this is how you end up with a guideline. So for specific intervention, and this one is an example on surgery, you would take into consideration that surgery has surgical complications. And you have to see whether this adds up to the benefit of the surgery or not. Just some examples. So in our guidelines, we have some examples saying you shouldn't do this or that. You shouldn't do, in this case, biomarker testing in endometriosis. There are some things that are weakly recommended, saying you might give this or you could give a certain interventions. There are strong recommendations saying it's recommended to do this or that. And then sometimes there is no evidence or there is no decision on what you should do. So then you could say, oh, both options are feasible and it's open to shared decision making. What it implies to have a strong recommendation is this is something that every patient should be offered, and policymakers could consider this in their regulations. For instance, if you recommend in a European guideline that hormonal treatment is recommended for treatment in endometriosis, this could imply that policymakers could ensure there's reimbursement for this treatment. Also vice versa, of course, if you say something is not recommended, they might skip the reimbursement. With weak recommendations, it's more an opening for shared decision making, where the patient can help to decide whether or not to apply something. We also have good practice points, which actually to clarify a certain recommendation. For instance, we had this recommendation saying hormonal treatment should be offered, but then you have a good practice point saying, well, there is no clear advice on to which of these hormonal treatments. So that's a point where you can say, well, you need to consider the side effects, the dose, what the patient wants in your shared decision making. And then we have research-only recommendations. We don't often, not that often use, but that's for specific things, mostly newer things, where we say, yeah, you could apply this, but please do it only in a research setting with approval, ethical approval in a research context, so not in clinical practice. The next step is stakeholder review, which is for some people a bit of an afterthought. For me, it's really important. That's why we put out our guidelines on the ESHRE website for 6 weeks. We invite everyone we know to give comments, and we really listen to what our people say. Whether something is feasible, whether it's understandable, whether the document is too big or too small, whether they need more explanation on a certain recommendation. We get all kinds of feedback, and we try to incorporate all of that in our guidelines. And we have a full report, each comment, what we did with it, and why we didn't modify anything in some cases. But it's still all explained, and it's very transparent and open process. Yeah, maybe. And then the guideline goes for approval, publication, and we have a process, of course, for updating as well. So these are the examples of our evidence-based guidelines, and Bryan will tell you more about one of them later on. In the whole system, while I'm a big fan of evidence-based medicine, it's not always applicable to everything. We got some requests asking for documents on how to do something in the lab, what is good practice in genetic testing, how to do a biopsy, how to do a surgery, how to do a pickup. The evidence-based methods just don't apply to these kind of documents, but you can't really say, well, then we don't give any advice. So we developed a methodology for good practice recommendations. It's really important, I think, to differentiate from evidence-based guidelines, because these documents are not evidence-based. They are based on what is available, but it's not the data from RCTs or whatever studies. Still, the methodology gives us the opportunity to provide guidance where it's needed, where there is uncertainty, where there is room for improvement in quality of care. And often these are very different topics, but still they need to be addressed. We have a separate methodology for that, which is based on the evidence-based guidelines. So it's a bit less structured. Rather than having real key questions, PICO questions, we define a scope and an outline of our document. Instead of searching for evidence and focusing really on PubMed, we go through a survey to see what is currently done in clinical practice, or we just ask the experts on the topic, and we try to collect data on specific topics from the literature. So if available, we still use these data. And then instead of having a whole specific method of defining recommendations, it's all about reaching consensus within the guideline group, within the working group. So in conclusion, we have 2 lines of guidance documents, our evidence-based guidelines and our good practice recommendations. Both have a structured methodology, and it's really important for us to be transparent on the whole process, as we want to make documents that are trustworthy and useful for people. The aim of these documents is to improve the quality of care in infertility and medically assisted reproduction, and the aim is also to help people, not to overrule them. And maybe this is the most important conclusion. These are the different documents we have at hand. We have the website on top, so please take some time to visit this website and to scroll through all the documents. They're all open, available for everyone. And for those of you wondering about my 1-hour rule, it is still the rule. We are planning a consensus meeting as soon as we see the data. Thank you.
Excellent. Thank you very much. We will discuss at the end. I can imagine the poor children of yours starting with these rules from the beginning. Oh, come on. So unbelievable. Okay, and now we move to the second presentation. This is the big man of ESHRE. That is, well, you can understand why I rate him as big. If I stand up, no, I won't. Next to him, I barely reach his shoulder, yeah? Okay, so he's an embryologist, Bryan, and he has a terrific experience with the certification of embryologists, of clinical embryologists in ESHRE. Now we are covering a slightly different aspect, but Yeah, just for you all to know. Okay, please, Bryan.
Grazie. Buon pomeriggio. Something like that. Anyway, welcome. I'm going to talk to you about one of the guidelines on medically assisted reproduction for fertility. So, MAR for patients with viral infections and diseases. Why do we offer patients with viral infections and diseases assisted conception? Well, they have a longer life expectancy than they used to have. We've got therapies out there, and they have an improved quality of life, and they have the right to human family, or a family, rather. The United Nations, of course, they have the human rights, and it's Article 16 that says that men and women of full age without any limitation due to race, nationality, or religion have the right to marry and found a family. And perhaps we could change that to say, without any limitation due to viral status as well. So how can we help as MAR professionals? Thank you. Sorry, am I shouting? We can explore the best treatment options. We can reduce the risk of virus disease and transmission and increase the chance of having a healthy child. It's not a guarantee, but we can do our best. We use evidence-based recommendations. I'm fine. I don't know about you guys. But we use evidence-based recommendations to prevent or reduce the transmission via horizontal transmission, which is person to person, so that's bodily fluids. Vertical transmission, which is the mother to baby, which is pregnancy, birth, and breast milk. And, of course, nosocomial, which is when they go into the clinic without an infection, unfortunately come out with an infection, which we never, ever want. So, as Nathalie pointed out, we have the guidelines in place. The MAR guideline came out last year. It was published in Human Reproduction Open, so you can freely download this and see all of the practice points and recommendations. I strongly recommend you do that. And there's also a patient information leaflet. Now, this is really, really useful. It's free to download, again, from the ESHRE website. I use this. I go to various clinics around the world and use it for the viral positive patients. It can increase the patient awareness of options. It's written in layman's terms, and it provides information on the interventions that can help you with the consultations. This is the contents of the leaflet, but I'll go through that now as part of this talk. So we'll talk about the two hepatitises, B and C, HIV, HPV, HTLV, and Zika. Then, most importantly, we'll look at recommendations for MAR labs. And then, if we have time, we'll talk about a few other viruses that you might be aware of. So, hepatitis B then. It causes acute liver inflammation, as all the hepatitises do. Up to 10% of people who have Hep B will have a chronic infection. There's horizontal transmission through blood and sexual contact. And there's vertical transmission, and then if the person is Hep B positive, the child is at a high infection risk. But we have a vaccine. This is one of the very few viruses where we have the vaccine. And 85% of the world's population is vaccinated against hepatitis B. That still means 15% isn't. And if you do have a child from a Hep B positive mother, then you would administer HPV immunoglobulins at birth, and you also administer the vaccination. Now, in the patient leaflet, we have this summary table where you have 4 columns for each virus. What happens if a male tests positive, what happens if a female tests positive, and then what happens if a couple tests positive. So whenever there's a non-infected partner, you vaccinate. You always consult with the infectious disease specialist, and then if the female's involved who's viral positive, then you talk about vertical transmission and newborn prophylaxis. During the MAR, you don't particularly choose a specific treatment other than for the infertility that they present with, and it is routine sperm processing for hepatitis B. And then after birth, at caesarean section, that's not recommended. Breastfeeding is not contraindicated, and as we've said, you vaccinate the neonate and you offer the immunoglobulin. Okay, hepatitis C, again, it's acute liver inflammation, but there's a much higher rate of chronic infection at up to 90%. Horizontal transmission is the main way, but not so much through sex, more through blood and sharing needles and things like that. But HCV is shed into semen, so you can do sperm washing to reduce the level of that virus in the final preparation. And there is vertical transmission, and the child would be at a high infection risk. So if we look at the table again, you consult before MAR with the infectious disease specialist, and for the female testing positive, you discuss the risk of vertical and horizontal transmission. You do semen processing in this case, but you do standard oocyte processing at the collection, and the semen processing is density gradient with washing, and then potentially sperm swim up as well. And then after birth, caesarean section is not recommended, but breastfeeding again is not contraindicated. So for both of these hepatitis with vertical transmission, the C-section and vaginal birth, they have the same transmission risk, and breastfeeding, it's not transmitted via breast milk, so that's okay. HIV. As I'm sure you're aware, it infects white cells and it weakens the immune system. There is no vaccine, but there is effective antiretroviral medication. If you consider those of us who are my age or older, how it used to be, we have a much less, we can reduce the viral loads now, so we can have the uninfected partner to have intercourse with the affected partner. Horizontal transmission does take place, blood and sexual contact, and HIV is shed into semen, so again, we can do sperm washing. And there is vertical transmission, but we need to reduce the transmission to the baby, so we do that via a C-section and combined neonatal prophylaxis. So if we look at the table again, this is a little bit more complicated, but if we look at the ones where the HIV is detected in the blood, then we need to consider the risk of horizontal transmission, and for the female, horizontal and vertical transmission. During MAR, again, we have semen processing. We can do that, and we can reduce the level, sometimes eliminate the level of the virus that we use, standard egg collections, and then after a birth, then we have C-section recommended if there's a detectable viral load, breastfeeding not recommended for the female positives, and combined neonatal prophylaxis. There was a paper in Human Reproduction about the HIV and HCV sperm washing. This is actually from several years ago, and they were talking about the fact that even when you do the sperm washing, it's never 100%. They reckon that about 10% of samples will test positive with PCR for one of the two viruses mentioned here. So you have to be really careful. Unless you do that PCR test, you can never really guarantee that that sample will be virus-free. HPV, there's about 200 or over 200 HPV viruses, and they affect the skin and the mucosa, usually the genitals and the mouth. Most people will test HPV positive at some point in their lives, and it is harmless for most of us. But there are high-risk HPV types, and they can cause cancer and infertility. Horizontally, it's easily transmitted through intercourse. And if someone tests positive for HPV, then you simply postpone the treatment until the infection is cleared up. And for the female, you'd have cervical HPV tests at least 3 years after birth, and then every 3 years up to the age of 29, and every 5 years thereafter. Breastfeeding is allowed with HPV. So with this summary table, you would discuss for all of those groups the possibility of postponing MAR until the HPV infection clears up. During MAR, there's nothing special that we do. Routine semen processing, and the fertility treatment is indicated by the parameters we're faced with. And after MAR, caesarean section is not recommended, but breastfeeding is not contraindicated. And I will recommend Andrea Garola. I saw him earlier. He's written a fantastic book on HPV, so I strongly recommend you read that. It's an excellent book. Okay, HTLV, human T lymphotrophic virus. HTLV 1 and 2, they affect the T cells, similarly the white blood cells to HIV, but they can cause T cell lymphoma or T cell leukemia, and they can cause spinal cord inflammation, but most people that get HTLV 1 and 2 have no symptoms, they're asymptomatic. There's no cure, the body can't clear the infection on its own, and there is presently no vaccine. Horizontal and vertical transmission takes place. Breastfeeding and caesarean section, we don't advise that. So you consult with the infection disease specialist, you discuss the risks of vertical and horizontal transmission beforehand, same routine semen processing, and the fertility treatment is on the parameters of the couple. And after MAR, cesarean section not recommended, breastfeeding not recommended either. Finally, I'm going to talk to you about Zika. And as you know, it's from the mosquito. The epidemic started in 2015 in Brazil. Most people are asymptomatic who do get Zika or are bitten by the Zika mosquito. But those of them, some people get Zika fever, and that's flu-like symptoms. Horizontally, of course, that's the main way of transmission. Sexual contact, blood and semen. And the couples are advised to wait 3 months after being testing positive for the virus or visiting somewhere where the virus is known to have a high prevalence. But the male tract is a Zika reservoir. And there's a paper out there just this year that shows that the virus can be detected in semen 370 days after the viremia and after the blood is clear. Okay? So it's an interesting one. And that's why the WHO says you wait 6 months after coming back from a Zika area or testing positive. And of course, vertical transmission is the scary one, because most people will be unaffected, most babies will be unaffected, but you will get congenital Zika syndrome, and that can range from clubfoot, something like that, but you can get microcephaly in about 30% of cases, and that's a reduced head size, reduced brain size, okay? So in summary, the summary table for this, you postpone mild treatment if you do test positive, and they're the times that we give in the ESHRE guidance. If it is detected during the treatment, you cancel the cycle, and C-section is not recommended, and breastfeeding is not contraindicated. However, I spoke with a colleague of mine in Latin America yesterday, and they said, actually, we do plenty of C-sections for Zika, because at the time of delivery, if the mother is testing positive, the transplacental transmission has already taken place, so the baby will be affected. Okay, and this is a paper by Das from the Indian group, and it's just talking about how the various viruses affect male fertility. I found this, it was actually just published a couple of weeks ago, and an interesting thing about this is it's got a really good table that shows how the various viruses do affect male fertility. So I strongly recommend you read that. I think it's free access. Okay, the important thing for you guys is lab safety. So what can we recommend for lab safety with viral patients, viral positive patients? Cryostorage. We hermetically seal the high security straws or cryovials. We no longer use vials and just put them in the nitrogen. The inner thread will not stop the nitrogen getting in. And we don't use the cotton plugs. We hermetically seal with a heat sealer. We have separate positive and negative cryostorage dewars. Okay? The viruses can transmit through the nitrogen. There's never been a case in ART, but there have been cases in other areas of medicine, so we're cautious. But you need to assess how many cryotanks you have. I know labs that have a tank for each virus and each combination of virus. If you're HBV, that's one tank. If you're HBV and HTLV, that's another tank. They have about 40 different tanks. I know other labs that have 2 tanks. They put everything in, and they say, we've done the risk assessment. So it's up to you to consider. The quarantine. Yes, if the infection status is unknown, say you're doing an emergency freeze for a cancer patient who's going to have therapy, then you put them into a quarantine tank. And just because I'm in Italy, I'll tell you that you guys came up with the term 40 giorni, which is your 40 days, because that was the 40 days that ships weren't allowed to dock in Venice or Dubrovnik during the Black Plague. Does vapor phase reduce cross-contamination compared to liquid nitrogen? Many people think it does. I mean, if you vapor, you won't get the transmission through the liquid, of course. I'm extremely cautious over vapor phase tanks. I've seen vapor phase problems where the ice crystals form and the liquid nitrogen doesn't get into the tank. So I prefer liquid nitrogen. It's up to you, but one of the recommendations would be to consider vapor phase. Disinfecting the tanks, another one. Should we disinfect the tanks if we know we've had a viral positive sample in there? Well, if you do, you can wash it with soapy water or detergent, rinse it out with water, but you're going to lose the warranty on that tank. So again, your decision. We should disinfect the cryo devices when we bring them out from nitrogen, certainly the semen straws and vials. So you wipe them with a disinfectant wipe, get rid of any pathogens in that area, perhaps between the liquid and taking it out. There will be pathogens in that area above liquid nitrogen. Use single-use sterile scissors. And a few papers here. Single personalized disposable vitrification containers. I was in Africa last week, and they have this. They have vitrification bath for HIV, a vitrification bath for HPV, and for the screen patients. So have one separately. Sterilise nitrogen before use. This is for Alessandra, her paper there. And also wash cryopreserved specimens in sterile liquid nitrogen before warming and thawing. And I will put a shout out to Lodo. I'm sure you will know Lodo, clinical embryologist, entrepreneur who's come up with that enterolizer device for sterilising nitrogen. General lab SOPs. We do disinfect and change PPE between cases. That's the best practice you can do. However, even when you do that, there will be instances of cross-contamination. There are several papers out there that say even with, you think you're doing the best practice, unfortunately cross-contamination can occur. So you need to be vigilant always. You could consider a separate equipment and separate labs for your viral positive patients, but again, you have to think about space and cost and the cost of the extra equipment. Double gloving. I would strongly recommend double gloving when you are treating viral positive patients. I do this, I go to Africa quite a lot where there's a lot of HIV-1, and I use different ICSI rigs. And if I switch from an RI rig to an Arashigi, the first couple of times I'll sometimes forget the needles are there and I go in, and you'll get just a needle pricking through your hand, but if you've got those gloves, it stops the puncture. Recommended SOPs, well, the ones that you've got in your labs, you use them for all your samples, not just the HIV ones or the viral positive ones. They're the recommended SOPs. You should treat every sample as potentially infectious. And if you think about the semen analyses you do, I've been to labs in the UK even where they don't wear gloves when they're doing the semen analyses. To me, that's daft. They don't wear gloves at egg collection. That's daft, you know. Simple things you can do because potentially every sample is infectious if they're not gone through the full screening. And we've got the revised guidelines for IVF labs, for embryologists. It came out in 2015, probably needs updating now, but it is a very, very valuable document. I've got time to talk about a couple of other viruses. CMV, I'm sure you're all aware of CMV. Horizontally transmitted and vertically transmitted. And there's a link with CMV to male fertility, as per that paper by Jaromi. But interestingly, I learned just a couple of weeks ago, I was in Denmark at one of the sperm banks, where they do the testing for CMV every 3 months. Now, we don't do that in the UK, but for their donors, they do it every 3 months because you can be CMV negative and then become CMV positive. Now, that sounds obvious, but it's the IgM that's the infectious one, okay? So if you're IgM positive, that's when you can infect potentially a female with that sperm. You can't use that sperm unless the female is CMV positive herself. But if they're IgG positive but IgM negative, then you could potentially use that with a CMV negative partner. This is controversial in the UK even, I was learning a lot, and I will now do 3-month screens for CMV on my donors as well. Other viruses, you might have heard of SARS-CoV-2, Ebola, white Nile, monkeypox, etc. With all of the viruses, if there is really high viremia, then potentially the testes blood barrier could be breached. But you have to be feeling really, really ill, and it's highly unlikely you're going to be going for MAR at that point. But the way we deal with it is we do strict triage and screening, as we have done over the past few years with COVID. In the UK, we had an alert come out from our governing body, the Human Fertilisation and Embryology Authority, just last month telling us about monkeypox. Be aware of monkeypox. So we wrote a letter to RBM Online because monkeypox is related to smallpox, and we need to be thinking, well, actually, how dangerous is this? But the letter got rejected. It was too speculative. I hope it remains speculative. So we've all been through the pandemic. What actions have we taken as a result of that? Well, it's highlighted the need to review our clinical SOPs. Hopefully, it's improved lab hygiene and good lab practice. It's improved the use of PPE. Before the pandemic, I remember talking to a senior embryologist about PPE. They didn't know what PPE was. I'm sure they know what it is now. Okay? You need to stay alert with all the viral positive patients that we treat. Read those guidelines. I'm sure you've all read them, but they are very, very valuable. And with that, I will say, stay vigilant, stay safe. Thank you.
Thank you, Bryan, for having shared in such a clear way this very pragmatic guidance for all of us during our clinical practice. We will have time for questions at the end of the session, so thank you very much. It's now my pleasure to invite, but he is coming by himself before the invitation, prior to the invitation. Antonio Capalbo doesn't need an introduction. He's an outstanding expert in reproductive genomics, Chief Genomics Officer, Juno Genetics, and currently the coordinator of the ESHRE Special Interest Group in Reproductive Genetics still. And he will be talking about chromosomal mosaicism in PGT. Please.
Thanks, Daniela. And Cristina, I come back to a normal Italian standard. And I would like to thank Giovanni, Andrea, and everyone from the General Life Group for this very much appreciated invitation. And in the next 20 minutes, I'm going to show you the work we have been doing with this working group at the ESHRE for releasing some recommendation about the clinical management of chromosomal mosaicism in PGT. So I will start with some background, some scientific evidence, just to show you where do we stand from, where we started our process of developing recommendations, and then I will go straight away to the main recommendation that we have agreed on. So, as you all know well, when we test aneuploidies, we are trying to look at a whole spectrum of aneuploidies, and these can range primarily from, embryos being euploid, aneuploid, meaning to say fully aneuploid, most likely aneuploidies that come from meiotic error and are therefore expected to be present throughout all the embryonic cells. And then we have this gray zone of mosaicism, which is extremely rare in human pregnancies, both natural and IVF-derived pregnancies, but sometimes has been reported a very high rate in preimplantation embryos. And I want to also to point out now what is the outcome that we can get based on different methodologies for studying the reproductive outcomes and competence of embryos in the broad spectrum of aneuploidies. So just to give you a sense of it, you can see that when we look at retrospective core studies, and Nathalie have shown already very well what are the strengths and limitations of different study types, but in particular going to the PGT and to the assessment of the reproductive competence of aneuploid embryos, you can see that retrospective studies usually do not make the use of aneuploid embryos because, of course, the procedure is made to select euploid embryos only for transfer. Mosaic embryos are usually left as last option for transfer, so they are deprioritized, downgraded, and transferred as last option, while euploid embryos, usually they always go first. This is not a good way to assess in an unbiased way the reproductive outcomes and to compare the euploid and mosaic embryos because, of course, mosaic embryos are always left for those patients failing with previous euploid embryo transfer. So this is creating a very important selection bias in the assessment. Another design that we can employ for assessing the reproductive competence of mosaic embryos or aneuploid embryos is the non-selection design. The non-selection design is when you transfer the embryos without prior knowledge about the genetic data. So you don't know when you're transferring the embryos if that embryo is euploid, aneuploid, or mosaic. In other words, you take the biopsy, you transfer the embryos, and then after you have recorded the clinical outcomes, you look at you link the genetic data with the clinical outcomes, and you can say how many aneuploid or how many mosaic implanted versus the euploid, and you can really assess in a more powerful way what is the predictive value of that specific diagnosis. Now, let's start from the fully aneuploid embryos. I think here we have quite good evidence suggesting that most of aneuploidies that we find in human preimplantation embryos are meiotic in origin. Here you see this picture that I always like to show because this is summarizing very well decades of studies in the origin and genesis of human aneuploidies in oocyte and preimplantation embryos, and it is really showing you how the euploidy rate into the oocyte, the red curve here, is shaping the human reproductive fertility over the woman reproductive lifespan. So in other words, you can say how the euploidy rate in oocyte is shaping the human natural fertility as recorded by epidemiological data. So this is meaning to say that aneuploidies that are meiotic in origin, coming from the oocyte or from the sperm, they are usually present in all the cells, and they are associated with clear clinical outcomes, meaning that this is information that we know how to manage, how to cancel patients on this information, because we know that most human embryos affected by meiotic aneuploidies, especially if they are monosomy, they do not implant. If for some trisomies, they may implant but result in a miscarriage, and very rarely they are compatible with life and associated with very well-known chromosomal syndromes such as Down and a few others. So what is the predicting value of uniform aneuploidies? This is probably data that now we get to know very well. We have recently collected all the evidence about the outcomes of the transfer of uniform aneuploid embryos. This is accounting for we have experience on over 350 aneuploid embryos that were transferred blinded or in an unblinded way. And as you can see here in this table that is coming from a paper that is on current issue of American Journal of Human Genetics, you can clearly see that in different clinics, in different settings, using different PGT assays, you can see that 98% of the fully aneuploid embryos, they did not make a baby. They did not result in a delivery when transferred back to patients. Most importantly, the transfer of these embryos, these aneuploid embryos, was associated with very high miscarriage rate, 86%. So I bet that there doesn't exist an accepted medical treatment where you have a failure rate as high as 98% with a risk for adverse event as high as 86%. So at least for uniform aneuploid embryos, I think we have very good evidence supporting the fact that these embryos shouldn't be used in the clinical setting unless under a proper ethics committee approval and during the course of a trial and after counseling patients about these outcomes. Now, let's get to the point of mosaic embryos. We know that already the ESHRE also suggested that there are, in a previous document, that there are many issues surrounding the diagnostic of mosaic embryos. In particular, we all know well that in preimplantation embryos, the situation is different, like from amniocentesis or CVS, where you can visualize the cells and count the number of abnormal cells versus the normal cells. In this case, we make an inference based on some bioinformatic analysis and data points, and usually we define mosaicism when we see an intermediate copy number in a certain range. This is, of course, there are limitations that are technical, in particular if you have technical variability and noise, this can never be distinguished from the presence of true mosaicism in a biopsy. We have another challenge, that is that all the thresholds that are available for calling mosaicism, they have derived based on cell line experiments that are very stable, reproducible, and do not mirror what's happening in a clinical setting. And also, by definition, we have the sampling bias. So if an embryo is a mosaic, of course, I don't have to tell you that depending on where you take the biopsy in the embryo, you can get different results. Now, the problem is that when we call mosaicism in this way, and in particular if we are overcalling and overestimating mosaicism, the couple will have to face many different consequences about this diagnosis. In particular, they will have to go through genetic counseling. They will have to evaluate the transfer of these embryos in a context of increased anxiety, distress. And in particular, we have seen with experience that the transfer of mosaic embryos became an indication for invasive prenatal diagnosis early on time, without even getting some more data about what is the actual risk of transferring mosaic embryos for the pregnancies or for the baby. But most importantly, the highest risk that we will see then with the survey that the ESHRE ran during the course of this activity is the potential wastage of embryos that are otherwise healthy and potentially viable. There are many reports where we have seen that most of the mosaic embryos, they never get transferred back to the patients. And what was the evidence to support all this practice before? We only had retrospective studies. This is just to show you one of the many retrospective studies that were performed in this context. And you can see that in this paper, mosaic embryos were associated with a slightly lower reproductive potential, slightly lower delivery rate as compared to the euploid embryos. As I was telling you before, there are several limitations. We're looking at the outcomes in a retrospective way. In particular, there is the fact that the mosaic embryos, by definition, according to the workflow in the clinical practice, they are always transferred as last option. So in other words, we are going to measure the outcome of mosaic embryos on those poor prognosis patients that fail with one or multiple previous euploid embryo transfer. So it's not really a fair comparison with euploid embryos. Before starting our working group and activity with the recommendations, we had also the publication of the first prospective non-selection trial that we did together with the General Life Group and Humanitas here in Italy. And in this case, what we did was to mask the diagnosis of mosaicism, because I think it made sense to get first insight about the predicting value of this intermediate copy number that we may define as mosaic before changing our clinical practice. And therefore, we report all these embryos below the 50% as euploid, and after the transfer, we could get an unbiased comparison between the two groups. And as you can see here in the outcomes, the main clinical outcomes, they were all similar between the euploid and the mosaic, even when stratified for low putative mosaic or moderate putative mosaic. Neonatal outcomes were similar, and we also checked some baby, some newborn by SNP array, and we did not find any evidence of mosaicism in those babies. Now, in this context of uncertainty and lack of standardization about this practice, I think it was a good initiative for the ESHRE to run this good practice recommendation on the clinical management of chromosomal mosaicism. This is the working group that was made up of many different experts with experience in molecular and clinical genetics as well as in embryology. The aim was to provide guidance on the management of mosaic embryos with intermediate copy number results after trophectoren biopsy without any reference to the reasons or indication of the genetic test. Of course, we already had some previous documents from other societies such as the PGDIS and COGEN, but of course the ESHRE consider worldwide to take their own step and recommendations. The methodology was first to run a survey. Probably some of you may have participated to this survey in 2020. Then we did a literature search, as Nathalie have shown you before, and then we got to an expert opinion of the working group to release the recommendations. The paper has just been submitted a couple of days ago, if I'm not wrong, to the Human Reproduction Open. This is the participation to the participant to the survey. We got 239 replies from 239 different ART PGT centers offering PGT, different type of PGT. And as you can see here, the distribution, geographical distribution was primarily in Europe. I had to just to go and to show only the main, at least for what for me were the main and most interesting findings of this survey. That is very long, and that you can access it to it soon. In particular, about the validation of the technology, was surprised to see that about 36% or 50% of the clinics or the respondents that they comment they didn't have any validation for calling mosaicism or for the PGT in general. And I think that this figure here, when we ask what are the thresholds for calling mosaicism that you are using in your practice, you know, there are some centers or some genetic laboratories using 30 to 70% of variation of number of normal to abnormal cells to call mosaicism. Others, they are using 20 to 80, and as you can see here, the situation is even more heterogeneous. There are centers that are reporting 40 to 70, and whatever combination we could find it into this survey, into this question. But most importantly, when we ask how do you deal with mosaic embryos in a cycle where no euploid embryos are available for transfer, 70% of the respondents consider discarding or donating to research mosaic embryos as an option. So we made a recommendation about how mosaicism should be reported in PGTA cycles. We consider acceptable either reporting or not reporting mosaicism. And the most important point is that if mosaicism is not reported in a PGT practice, this should never be defined as aneuploid, because there is some center that is, I mean, if the clinics doesn't want mosaic reporting, they are designating the embryos that are of an intermediate copy number consistent with mosaicism, they are designating it as aneuploid. So I think this was very clear here that this is not acceptable. And another important recommendation is that I think that the word is about the wording. So since we are not visualizing mosaicism, there are many issues about this type of diagnosis. A wording such as putative mosaic indicating mosaicism or suggestive of mosaicism is the recommended option to report these findings. And then we also made quite clear that if mosaicism is reported, it is recommended that stringent criteria are used for designating the range of mosaicism to avoid the risk of overcalling mosaicism. In other words, we shouldn't be using like 20 to 80% of very wide and less accurate thresholds for calling mosaicism, but we should try to narrow the range where we report mosaicism and avoiding any kind of precise estimation of mosaicism such as 65%, 63%, because by the way, we do not even know the number of cells that are within the biopsy, so it really doesn't make any sense to provide exact numbers of mosaicism in a single trophector multicellular biopsy. Validation of all methods used for PGT is recommended, of course. We should follow the EQA schemes. As the presence of mosaicism is an issue when analyzing trophector biopsy sample, it is recommended to include mosaic samples in the validation studies. And of course, we have to make clear in the genetic report and during the consent form all the procedures, limitations that are associated with this type of diagnosis. I think it is also interesting to comment on the embryo transfer policies. In particular, for selecting embryos for transfer among low-range mosaic, the trophector biopsy PGTA results should be co-evaluated with embryo morphology and preferably not be assessed on its own. This is a significant deviation from previous recommendation by the PGDIS that were suggesting to select the embryos only based on the mosaicism without that many consideration on embryo morphology, which we believe that is an important parameter to consider. And it is also important that mosaic embryos in the low range should be considered at the same strength as euploid embryos for what consider the disposal of these embryos. So we should not make a new IVF stimulation cycle if mosaic embryos in the low range are still available for transfer. Also, we did not recommend to make rebiopsies because a potential solution to investigate further if there is mosaicism into an embryo is to make some rebiopsies of the embryos, and we consider that this is not going to help in the understanding about the true chromosomal constitution of the embryo, and can also have a possible negative impact on further embryonic developmental and implantation. And for what concerns prenatal testing, I think also this is a very important recommendation because the working group, of course, confirmed the fact that genetic counseling on prenatal diagnosis should be offered to all women who become pregnant following PGT, but a finding consistent with low-range mosaicism in a clinical trophector biopsy does not represent an indication for invasive prenatal diagnosis itself. And this recommendation is supported by the fact that now that we are accumulating data from the transfer of putative or apparently mosaic embryos, it is clear that it doesn't seem to be an increased risk associated with having a mosaic pregnancy following the transfer of a low mosaic embryos. So it seems that the level of mosaicism in pregnancies is similar to what we experience in natural conceptions, and also therefore this shouldn't be considered as an indication, additional indication to go through an invasive procedure such as CBS or amniocentesis, of course, everyone is recommending and encouraging to obtain follow-up data on babies born after treatment. So in conclusion, I think that we have also worked to develop some ideas on future research that are needed into this field. For sure, gain more insight about the clinical predictivity of mosaic classifications, what is the accuracy of mosaicism detection of mosaics and mental imbalances, where we cannot make any recommendation about segmental aneuploidies. What is the outcome of mosaic embryo transfer with regard to pregnancy and offspring? To what extent PGT-SA can be improved to detect true mosaicism? We know that we can work further with genotyping information in order to try at least to fine-tune the PGT-SAs to tell us this is a meiotic aneuploidy, this is a mitotic aneuploidy, and this is expected to improve a little bit the clinical utility of the assays. And then also what is the potential value of an IPT for in the prenatal follow-up after a mosaic transfer. I want to say that by the time we finish this activity, till today we get some more insight about what is the clinical predictivity of mosaic classification, and this is the last paper that I wanted to show you that is going to be presented at the SRM this year. Is another big effort of a non-selection trial, a prospective non-selection trial that was independently run by the EVRMA and Juno Genetics, and as you can see here, in transfer of thousands of Y chromosome negative mosaic embryos, they observe exactly the same live birth rate as the non-mosaic euploid embryos. So this is very fresh and new evidence, additional evidence about the fact that even with different assays and in different clinical settings, the mosaic embryos in the low range, they get similar clinical outcomes as euploid embryos when analyzed in a prospective non-selection design. So I really want to take the opportunity to thank all the members of the working group, particularly also Nathalie, who has coordinated this activity. And of course, we had our times. Sometimes we had to discuss on several points, but I think at the end, this was a very well-developed document, and I really hope this will help the clinical practice and many more patients to get a more evidence-based assessment of their embryos. And thank you very much for your attention.
Thank you, Antonio. Looking at the faces of the participants, I cannot even imagine the discussion that was in the group. I mean, wow. I just want to underline that the document is still waiting for the final approval. So from the EXCO, right? The document on mosaicism, chromosome mosaicism, and it won't be published in September, so we still need, we still need a little bit of time. Okay, so now we go from one difficult topic to an even more difficult topic. That is the status of embryologists. So I'm afraid that we won't have any satisfactory answer at this point. And Lucia De Santis is going to enlighten us on the topic.
Good afternoon. Thank you very much to Andrea and the 9.baby family, and now the General Life Big family for this invitation. And I have to say this is an ESHRE session, I guess. So we will talk about ESHRE again during my presentation. So I was asked to give a talk on the update of the professional status on the clinical embryologist, and these are my disclosures. I am the Italian Society of Embryologists immediate past president. I'm associate editor of Human Reproduction and part of the board of inspector of the ESHRE RCC program. And this is briefly the agenda I'm going to follow, mainly focusing on the last three points. So we will talk about the evolution of clinical embryologists, especially in terms of staffing, tasks, rules, and responsibilities of different laboratory team members, educational requirements, current status of clinical embryologists in the health system. That means not only public, as we think sometimes, but public and private, and the mechanism for improving their status. And maybe something new will come over. But before going through this talk, I want to thank my friend, Borut Kovacic, that helped me in doing this presentation, and he's member of the steering committee for certification, and so probably one of the best person we can have to solve the problems of the embryologists, and he took care a lot of embryologists in these years. When we work as embryologists, we are working in a health care facility, and this means that we have to be familiar with strict rules and responsibilities. We have to understand the hierarchy of health professionals, and we have to be subjected to a really long theoretical and practical training to arrive to work in autonomy. As it is correct and expected and shareable, we have expectations, and the expectations are prescribed practical training, stepwise involvement in all the lab procedure, step by step, regular upgrading, defined expected level of competence, and especially opportunity to progress up the hierarchy of the health system, which is not the case for many of us. During our practice now, with the strong reality we have to face, and we have to learn the lesson, and the lesson we learned are that we work with a very high level of responsibility. We have to ensure very strict, and Alessandra will talk about later, standards of safety, quality, and compliance with European Tissue Cell Directive, our competent authority. And we equally contribute to the success of infertility treatment. We work many times outside of standard working hours, and often, so the risk of burnout that generate risk of errors. And often we are not recognized as status, despite the direct involvement in the therapeutical process. And if we focus on this last topic, with Borut, Borut presented some of those slides at the ESHRE campus, the haute cuisine of IVF in Barcelona. It was May, I guess. And this interesting abstract was presented at the ESHRE Virtual 2021. First name was Alex Varghese, which is an outstanding and very skilled and experienced embryologist. And they try to understand with these kind of charts that are called sentimental wheels, how the embryologist think and faces at the clinics with respect to the professional level, at a personal level, but at the end with open answer. And the summary answer of the abstract of the study was that there are a lot of weaknesses in the process. Embryologists are essential professionals, but they are less satisfied in many, many different quantifiable aspects, especially education, but moreover recognition, remuneration, compensation, cooperation, and career and certification. Don't forget this word. But they love their job, and this is the most important challenge, and this is the real strength of this. Who I am an embryologist. And this is very important because under this brick we can build what is going on. Why don't embryologists have a professional status yet? Can be probably due to different reasons. Many of these reasons are not direct responsibilities of embryologists, but we are trapped in the staffing norms of the early IVF era. We are undergraduate in terms of education compared to other health co-workers. We have informal forms of education. This informal has to be totally changed. There is an absence of a universally recognized training program, rigidity of health systems, lack of support, and rationality reasons. So, since we don't want this is the situation, but most of the time this is the situation, since we don't want to be ninja, but we want to be embryologists, why should education be organized This is very easy to understand because we have to actively participate the therapeutic process and especially gaining the trust of clinician and patients. So we want to be part of the process in the same fashion as the other personal professionals involved in the treatments. So what is needed for complete organization is a curriculum, the syllabus, the logbook. Most of these things are really easy to understand, but there are other tasks we have to fulfill. One is the quality of trainer, the quality of the place where you do the train, so the accreditation of these centers that grow the professionals, the verification of knowledge and skills, and this is the reason why the certification is so important for clinical and senior embryologists, and moreover, the maintaining of the competence. So it's not that once you acquire the title is forever. Medicine is evolving, science is evolving, and the embryologist has to maintain a level of competence because it's a person involved, like the physicians, with patients in a very complicated and delicate process. If we look at the literature, the state of art shows mostly two milestones papers on the same topic, on the professional status and education of clinical embryologists. One was published on ABM online and was the Alpha Consensus meeting. Even the Italian Society participated as one of the European society involved, and then the paper that Borut Kovacic published in 2015 that was related to a survey. At the time I was the ESHRE Italian CNR that was published on the survey that the ESHRE proposed to all the CNRs, and was just concluding that there are differences in training and differences in expectations, and there was not a sort of uniformity in the European countries with respect to the professional status of clinical embryologists. Very few papers came out during this year. This spring came out this sporadic paper that was just a description of peculiar Italian situation, focused on the career within the national health system. That was mainly a review of achievement obtained by other groups. But that was interesting because it means that there is still debate on this topic. For this reason, in 2020, just few days before the pandemic stopped our activity, lives and meetings together, this year during the annual meeting, organized a pre-course where we met the European colleagues, and we tried to understand what was going on 5 years after the publication of Borut Kovacic paper. And we involved 12 scientific society, and we proposed a survey before the meeting, 1 month before the meeting, and then we collected the results. I don't want to go through this topic that much, but we, me, Lello, and the steering committee on certification are still working very hard on this, and I think we hope to propose some summary of this part of this work in the future. And lead embryologists were involved, and at the end, this is just one kind of the questions we ask the people invited to the meeting. Which study profiles work in the IVF lab? Just this was the first question, just to start. And take a look at this list of different professionists working in the IVF lab, because this makes sense for something we are going to discuss in a few minutes. And as you can see, there are very wide and dispersed answers. No consistency between countries, at least regarding this first question. So At the end of the survey, we concluded during the meeting that some countries have no official national document. The clinical embryologist was not recognized in most countries as a profession. There was a high variability in the minimum qualification to become clinical embryologists. Most countries do have certification programs. There was a high variability in the definition of minimum number of clinical embryology in the staff, and in particular, number of treatments per year, so the workload is sometimes too much compared to the number of embryologists present in the lab, and some countries do not have specific scientific societies for embryology, so steps behind. We are, as the Italian Scientific Society of Embryologists, trying to put in place a certification, but it's a very hard and difficult pathway, we believe, but it's hard. And then a few weeks after our meeting, when we were at home with the COVID, this wonderful paper came out in ESHRE pages on human reproduction open, and I think all the embryologists has to read this paper irrespective if they obtain the ESHRE certification or not, but because it's so important going through the single aspect of this paper. The conclusion that the exam proposed is extremely interesting. It is considered the most recognized and appreciated form of certification for embryologists. It is extremely appreciated, but it is difficult. It is divided in 2 steps, and there is a lot of post hoc analysis of the data, ruling that this certification is pointing out differences in the preparation, in the background of the people attending the exam. And again, you can see here the distribution of the exam in its basic study fields. This is the analysis of the attendees 2016-2018. And again, you can see that there are many, many different study profiles that are employed in the laboratory, in the IVF laboratory. Of course, there is an impact of candidates' academic degrees on the success of the exam, both in clinical and in senior, most evident in the clinical, because if you hold a PhD, it's very easy, you will pass the clinical at the first attempt, but when you go on the senior part, there is no statistical significant difference, but it seems that the higher is your academic degree, the easiest is the performing in the exam, and I know very well, I'm the life representative of this. And when you go through the differences, you can see that, for example, a country like Italy has quite really a relatively low number of applicants for the senior compared to the clinical. If you do the comparison with Spain, for example, that has more or less the same number of members in the ESHRE, like Italy, but they have more senior embryologists certified. This graph is irrespective of the number of attempts you do to succeed in the exam. So, although we have on our menu in Italy a lot of dishes with courses we can serve with good quality postgraduate training, and also on the other side of the channel we also have outstanding menu to propose to attendees. This explains why ESHRE certification is so important and so considered. The ESHRE made a paramount effort that we can divide in 6 steps, and I want you to focus on the last 4 because there was the international examination for clinical embryology, the analysis of a clinical embryology status in Europe, which correspond to the publication of board's paper, and then the continuing professional development system credit, the registry of certified clinical embryology. And now what we call the leap in quality, I would say. It is the utilizing methods to homogenize all the characteristic of the applicants in terms of titles, because coming from different countries, it is difficult to understand what kind of preparation, of what kind of study title this applicant has. And the other achievement was to perform the exam under the EUMS and CESMA, the Council for European Specialist Medical Assessment, that made the exam an e-exam, right? So more reliable, better control, faster test evaluation, and especially post-exam analysis like the one made in the paper of 2020. And then now, the last step, the center accreditation of training program, because where you learn makes the difference. So to sum up, embryologists have more than proven their indispensable role in art. They act as high professional health workers. They participate in the credit system of continuous medical education, and this is essential to maintain active status. Within ESHRE, all the conditions for the European recognition of the professional status of clinical embryologists, we believe, are fulfilled. Of course, at a national level, since we are in Italy, and I also want to talk as the past president of SIR, and now Valerio Pisaturo is the current president, we want to stress that at the national level in SIR, we are promoting all initiatives to achieve, in agreement with academic institutions and scientific societies, the full recognition of the clinical embryologist. I want to acknowledge my colleagues, and especially all my colleagues in SIR that allowed me to have 4 wonderful years of work together. Thank you.
Thank you, Lucia, for shedding light on this sensitive subject. I'm confident that several comments will follow your presentation. And it's now time to move to our last lecture before the discussion session. The topic is more and more challenging, coding in medically assisted reproduction. However, we have the right person here. Dr. Alessandra Alteri is a senior clinical embryologist at San Raffaele Hospital and senior deputy for the special interest group, Safety and Quality in Art. So please, the floor is yours.
Thank you. Thank you. Thanks to Andrea and Giovanni for inviting me today to talk about a topic so boring, coding in medical assisted reproduction. So first of all, I'm going to provide you a general overview about what the coding is and why so important and boring. And secondly, I give you a general description about the single European coding and when we should apply it. And finally, I provide you with some practical examples related to the use of the single European coding, SEC, in IVF. So let's start with the definition of traceability and coding. The concept of traceability is crucial to link the donor with the recipient, and in our field, with offspring born after our treatments. Traceability means the ability to locate, identify tissues and cells during every step. And in order to have an appropriate traceability, we must have a system for unique identification of tissues and cells for human application, including a donation identifier and also a product identifier. So the coding in our labs is mandatory, and each IVF laboratories must have an effective and accurate system to uniquely identify, trace, and locate reproductive tissues and cells. everything, always. So it's important to have a proper identification system, ensuring that gametes and embryos are correctly identified at all times. Also, ESHRE, in guidelines for good practice in IVF laboratories, recommended the use of a unique identification code, and most importantly, all devices containing biological material, dishes, tubes, cryo devices, must be clearly and permanently labeled with a unique patient identification code and also a date of treatment. But be careful. Be careful because we must code our devices in a correct way. Because unfortunately, some embryologists mark the devices twice, increasing the risk of error. For example, as you can see in this slide, if your witness does not realize that on this cryotop there are two numbers related to the embryos, number 3 and number 1, it would be a disaster, especially in a PGT cycle. And the same happens when we have a dish with a label on the side with a patient name and another label on the top with another patient name. Also, in this case, it could be a disaster. But the coding is very important in the donor program, the donation, and with increasing movement of reproductive tissues and cells across borders, the capacity to uniquely identify them is essential to ensuring traceability and biovigilance from the donor screening to the human application. But the real question is, do we have a code, a single code in Europe, and what does the legislation indicate us? So, as early as 2004, the Mother Law, the Mother Directive in IVF, recommended to design a single European coding system. This concept was enriched in the Directive 86 in 2016, established that a single European identifying code shall be allocated to all donated material. But 9 years later, the Directive 565 finally provided a comprehensive definition of the single European coding, the SCC, indications on its application, as well as obligations of the tissue establishments, our IVF centers, competent authorities, and also the European Commission. Italy transposed the provisions of this directive, the directive number 256 in 2016. But when should the SCC be applied? The SCC should be applied to all tissues and cells for human application, but fortunately for us, with some exceptions. First of all, no SCC for gametes and embryos from partner donation. So we must generate SCC only for gametes and embryos from non-partner donation. Other exceptions are when tissues and cells are distributed directly for immediate transplantation to the recipient, and when tissues and cells remain within the same center. Moreover, we don't generate SCC when tissues and cells are imported into the EU in the case of emergency, and also when tissues and cells that are imported from non-EU countries into the EU remain within the same center. But it's very important to know the structure of the SCC, because sooner or later you will generate it. And so, as you can see, the SCC consists in two elements: donation identification sequence and product identification sequence. Donation identification sequence indicates the origin of tissues or cells, while product identification sequence describes the product, the type of tissues and cells. The donation identification sequence is made up of country code, tissue establishment number, and unique donation number. The unique donation number is so important because we have one unique donation number for one donation event. Because a donor can potentially donate on several occasions. For example, a donor can donate eggs performing several oocyte retrievals. So one unique donation number for one donation event. The unique donation number is created locally by the tissue establishment, as in Belgium, or centrally by the competent authority, as in Italy. In fact, we have an Excel file provided by our competent authority. On the other hand, we have the product identification sequence. And so, in this case, this sequence is made up with the product coding system identifier, product number, split number, expiry date. For gametes and embryos without expiry date, we can put 8 zeros. The product coding system identifier, very easy. We can put the letter A. The letter A, because in Italy our competent authority decided to use as product coding system the system ISBT 128. Why? Because this system contains many products in terms for tissues, in particular blood, quindi very important for transplantation field. Here is the EU coding platform, consists of EU Tissue Establishment Compendium and EU Tissue and Cell Product Compendium. The Tissue Establishment Compendium is a register, and here you can find all information about tissue establishments authorized by competent authority and the code. Well, the Tissue and Cell Product Compendium also is a register, and you can find all product in terms of cells and tissues. So let's move on to practical examples, and let's consider two cases. First, Alessandra Alteri as a donor, and second, Alessandra Alteri as a recipient using ovocytes imported from Spain. Okay, let's start with the first example. I would like to generate my SCC. First of all, I check the tissue establishment code, and if you search into the platform, into the compendium San Raffaele Hospital, I can find 3 tissue establishments, one of which is Centro Scienze della Natalità. It's my IVF center. So in my case, the code is IT, Italy, and 009894. In order to generate my unique donation number, we have an Excel file provided by competent authority, and if I fill with date of the donation, surname, name, fiscal code, and date of birth, I can obtain my unique donation number. Okay, regarding product identification sequence, I put letter A, as product coding system identifier, as I mentioned before. The product number, very easy. You can consult the platform. If you search ISBT 128, you can obtain many products, in my case, oocytes, and the product code is R308. In fact, going back to our Excel file, there is a drop-down menu, and in the case of oocyte, the code is R308. As split number, I put 001, means that it's the SCC for the device number 1, and as expiry date, I put 8 zeros. So we can generate my SCC. Very easy. Let's move on to another example. In this case, I'm a recipient, and I would like to use eggs from Spain in Italy, in Milan. In this case, the SCC has been generated by Spanish colleagues, and in this case, as a product coding system identifier, you can find the letter E and not A. Why? Because the Spanish competent authority decided to use another product coding system different from Italy. Well, my Italian colleagues perform ICSI, freeze my embryos, thank you, but I would like to move my embryos from Milan to Rome. Well, in this case, what is the SCC? In this case, the SCC, in this case, we take the SCC from Spain, from Spanish eggs, okay, and we change only the second part. In particular, we change the product coding system identifier and we put the letter A, product number, in this case R309, because in this case we have embryos, and stop. It's very important. The first part of the SCC remains the same, ensuring the traceability of the donation, of the Spanish donation. That's all. But it is mandatory to apply the SCC on devices? In theory, yes, because the SCC shall be applied to all tissues and cells distributed for human application. But where the label sites precludes the application of the SCC, for example, our cryotops are too small, the code shall be linked to tissues and cells packaged with a label through the accompanying documentation. But let's see the European scenario regarding the use of the European single coding. And for this reason, the ESHRE Special Interest Group Safety and Quality in ERT performed a study based on a survey distributed among all ESHRE members. And as you can see, results show that over half of the respondents are using the SCC in their center, fortunately. It's very interesting, the answer of the question, how do you define the 13-digit donation code, means the unique donation number? Well, half of the respondents makes the code alone in their tissue establishment, in their IVF centers. For others, the SCC is created by competent authority, like in Italy. Finally, the SCC is mostly applied on companion document. Using data derived from this survey, we perform a SWOT analysis in order to shed light on a different aspect of the SCC management. And as you can see, the strength of the SCC are to guarantee traceability, to have a uniform identification code, and the SCC is easy. The SCC, in fact, increases communication network tracking reproductive tissues and cells. The competent authority can immediately check donation and donors, and also a unique identification code facilitates the traceability when adverse events or reactions occur. But on the other hand, unfortunately, currently, the SCC shows some weaknesses. It's too long, poorly manageable. It could be an incompatibility with the coding system already used, and also to transcribe is a time-consuming activity. So this issue led to an increase of error in transcribing, or failure to identify donation donors, as well as failure to identify potential adverse events related to the donation. In fact, many adverse events and reactions in the donation program have been described in literature, so the traceability is so important. Well, we can conclude that an effective traceability system represents a crucial aspect in medical assisted reproduction treatments, and it's guaranteed by using a unique identification code. From 2017, the use of a single European coding is mandatory for non-partner donation, with some exceptions. But the SCC ensures the standardization within the EU, but the scenario in Europe regarding the use of the single European coding is still heterogeneous. Thank you for your attention.
Very good. Congratulations, you made boring stuff interesting enough. actually. This is part of the activities that embryologists have to do. Okay, may I ask the other speakers to come to the podium, and then ask the audience for questions? Keep in Nathalie's. Okay. Okay. Keep into consideration that the more questions and quicker that you make, and the faster we close the session. So, maybe any question from the audience?
First row.
First row is always very active. First row.
Thank you, all the speakers. Nathalie, you described a specific point in the process leading to the production of guidelines, recommendation papers, stakeholder review. Now, could you please further emphasize that? Because I think it's a great opportunity for people outside the working group, and therefore professionals in the field, to make an impact on documents, even raising points that are not necessarily shared in terms of opinion by the audience itself, by the stakeholders, with reference to the elaboration made by the working group.
Yeah, as I mentioned, I think this is a really important step, and how we practically do it is we publish our documents online and we send an email to whomever is in our database. We ask national representatives also to spread the message, because we might be writing something that's not applicable in the Italian context, or something that doesn't really, or we may even have a mistake or whatever. So this is a really important system, and practically it's very simple. As soon as you get an invitation, you send us our feedback form, and we will look into every comment we get. So everything is always very helpful, and yeah, everyone has his own perspective, and I think it's really important that we take along people's perspective and make sure that our documents are feasible and usable, the final version at least.
Can you also make a comment about the relevance of the guidelines for the policy makers, especially for the new regulation on blood, tissue and cells that give a lot of relevance to scientific experts?
Yes, and I think that's something we still need to work on. I think what changed in the new tissues and cell directives, or the new proposal for the regulation, is that it will be referring to the EDQM guide. So I think we have a role in collaborating with EDQM and help them to use our guidelines as a basis for their documents, or at least be consistent with them, and make sure that we don't say something else than EDQM, and that's then becoming the regulation. So there is some work to do on that perspective. And I think the knowledge that we have from our guideline program, from all the people who have worked with us and know how to interpret evidence and know how to make recommendations, will surely help EDQM, well, if they, in the end, will use our experts in their panels and use our documents in their guidance.
Good, thank you. And maybe okay.
Can I have a question to Antonio, please? Thank you very much. I really enjoyed your talk, and I'm very much interested in chromosome instability in early embryos. And then, yeah, we did many trials also in sheep. Work on sheep as a vet, as you may know now. And if you check, fertility is not an issue in sheep. They are very fertile, they don't have any issue, any problem. But still, if you do, karyotype in an early embryo, we'll end up with 40% of them having mixoploid, we call them so. And of course, if you take these embryos, you put them into the sheep, they get into nice lumps. So is there, well, David Albertini is not here because, it is very much convinced that aneuploidy or mixoploidy is a physiological trait of the early embryo. And could you comment on that, please?
Yeah, sure. I think we should divide this answer in two different points. One is biological, one is clinical. So from the biological standpoint, I think we have a clear picture about the incidence of mosaicism in later stages of the pregnancy, where we can really assess the tissues, we can count the cells that are abnormal, we can visualize them. We are less biased from the issues that are associated with working on single cells. Okay, no, the problem that we have in PGT is that we're working on a single cell or very few cells, like 4 or 5 cells, and is always prone to bias, to some technical variability that we need to account for. So what is the incidence of mosaicism in human pre-implantation embryos? I think best estimates can be in the range of 3–4% of human embryos being mosaic at the blastocyst stage. But this is a kind of rough estimations, because at the end we cannot accurately assess every single cell of the blastocyst. The human blastocyst should have around 200 cells, so ideally we would need a methodology that is extremely accurate on single cell and look at all cells of the blastocyst, and this is not feasible today. So if 40% of embryos are mosaic and there is 1 cell abnormal out of 199 normal, we still don't know. The important point that we have is to try to define what are the clinical criteria that we should use in diagnostics in order to maximize the accuracy of pre-implantation genetic testing for aneuploidies. And I think what we're seeing today is that we have very good evidence-based method to divide embryos as aneuploid and euploid, and to get very good prediction upon the clinical outcomes. Then, of course, biologically wise, it's very interesting to expand our investigations on the incidence of mosaicism, and this is something that is ongoing. For instance, probably many of the chaotic and complex embryos that have many different servos during the first division, they arrest during pre-implantation development, so they do not get to the attention of PGD when done in the blastocyst stage.
Ho una domanda per Antonio. Antonio, hi, thanks for talking. You are in the working group that are writing the recommendation for embryo mosaicism. So the question is, why ESHRE working group still has not published the recommendation that are announced Science Month?
Well, they are submitted. As I said during my presentation, they are they've been submitted 2 days ago, so they are under review. 2 days
okay.
ago, yeah, sure. They will go through a revision round, and then, hopefully it will be published.
I have a question, if I may.
Sure.
Oh, yeah. In the meantime, I would like to make a not politically correct question to Lucia, but I have the right because, correct me if I'm wrong, I'm the only gynecologist here on the stage in this moment. So I would like to ask you, what's the role of the gynecologist in the recognition of the role of the embryologist?
Which is the role of?
The gynecologist, the medical doctor, which works with that embryologist in the recognition of the importance of the embryologist in the clinical process of...
The role of gynecologists is not difficult, so I think they can complain. And is to help embryologists in their training and let them be able to go and take the opportunities to acquire knowledge and encourage them to do the certification of ESHRE or the competent authorities, if provided, of the National Scientific Society. But if the gynecologist will ask for certified embryologists, the embryologist will be more motivated to do it. So, of course, if they live in the lab and they know there are societies around, there are certifications, so I think this is important. So the gynecologists can help very much to grow up their staff.
Thank you. It seems to me a very clear message. There is a question by Laura Rienzi, please.
So I have a question.
Andrea wants to add something.
I have a question to all of you that have been involved in the generation of these very important guidelines. We all know that, we all say that stakeholders are very important. We all say that the 6 weeks of open access of unpublished guidelines is important. But to which extent these guidelines are changed after the stakeholder? I mean, can you make an estimation? Because I'm not sure that, although there is a lot of comments that arrives, I mean, I don't know, I'm a stakeholder, so I'm asking you, to which extent this is going to effectively change the guidelines that have been prepared by experts month and month, and maybe they're not so prone to make changes? This is a question.
Well, we do make a lot of changes. Some things are, I always subdivide in comments to the content, people really disagreeing with certain recommendations. And in that case, we adapt nearly 50% of the comments we get to the comments, to the content. And then we have a lot of comments as well to the language, the format, sentences that are not clearly formulated. So in that group, again, another 50% is taken into consideration. So it is not that we just say, well, we don't agree with this comment and we log it and leave it as that. So, and then for the last guideline and matures guideline was 250 comments. So that means that at least 100 of them have really changed the content and the formulation of the recommendations.
If I may add something on this point, because this was my experience with this recommendation on mosaicism. And Nathalie, I'm confirming if I'm correct. So now what I saw with the stakeholder review is that all the reply, there was kind of selection bias in the reply, because everybody that was in agreement with the original version, they did not answer or did not provide any feedback or comment, while all the ones that were in disagreement with some points, they were the only one making comments. So I think probably we should also try to stimulate the ones that they agree or that they have some additional comment, but in a positive sense also to answer and to apply to the stakeholder review, because otherwise it's very biased, the feedback.
Did you receive comments also from patient association? I was not thinking about experts, sorry. I was thinking also about patient association or other associations.
Of course, but not for chromosomal mosaicism.
Okay,
for obvious
very technical.
But for instance, for endometriosis, we wrote to all the European patient organizations we have contact details of. So we do include them. With patients, it's difficult to really comment on this clinician version because it's a very heavy document. But we do share also the patient version, which is much more easy for them to comment on. And actually, the content is more or less the same. It's just another way of formulating things, and it's easier for them to comment. We do try to include patients also in the stakeholder review, although it's not as easy as reaching out to clinicians and professionals.
Thank you. Thank you for your job also.
We have time for a quick question. Thank you. Yes,
it's just a curiosity, because Lucia, you showed the slides where the Spanish embryologists just apply for the senior embryologist status for the ESHRE, and the Italian they don't. Is there a reason? So they know better English, or they are employed faster?
No, maybe it was not clear, but I underlined that it was the number of passed exam irrespective of the number of attempts. So in that, many Spanish senior embryologists certified. There are also people that repeated many times the examination. So it's not that they pass more than the other countries. There is no difference in passing rate. What it is that they apply more than Italians do. And in Italy, there was another phenomenon that it was not described in the paper because it doesn't go specifically in the countries. Maybe Catherine is not here, but probably Catherine Class would help us. There are some countries that have a number of attempts higher than others, like Italy, Poland, the Swedish, for the junior, for the clinical, not for the senior. But when the certification went out in 2007, it happened that there was the possibility for many, let's say, senior embryologists to grant the certification without the examination. For this reason, in Italy, there are a lot of senior embryologists, senior, that obtain the title, not via the examination. In the forthcoming years, also because the exam was in English, because at the beginning it was granted in English and in the language of the hosting country, if I remember correctly. Then the exam came over only in English, and it is historically very difficult. There was a decreasing in applicants in Italy. So there is a lot of people, let's say, that if had to take the exam, probably won't pass.
No, yeah, but don't you think that they don't care so much because they cannot use it to get employed somewhere or to go to a hospital?
This is probably a drawback, a side effect, because they know that it is so difficult, they do it, but this doesn't change that much their life.
Okay, if I may, I would like to ask a question for Bryan. Bryan, your experience in Africa, if I remember correctly, does it tell you that these guideline and recommendation papers are well received in those countries for guidance?
Yes, they are well received, but I do find when I go there that HIV and Hep B are a bit like the flu. So I find myself gowning up and putting the gloves on and doing everything to the letter, whereas the gynecologist perhaps will just do the collection and as per any other collection. However, they do read the guidelines, absolutely. And when I go, I mean, the virus one, but also the ESET one, single embryo transfer. I struggle so hard with trying to get the guys to put back one embryo. But we will get there eventually, and they are very on board with the ESHRE, coming to the meetings and learning from us. So.
Okay, I think that I want to make a very last question to Alessandra, and where are you? Did you take a look at the Notify library recently? Okay, how many reports did you find from Italy of adverse events?
It's a good question because the big problem for the Notify library is to collect the adverse events reaction. Generally, the competent authority, for example, in UK, because UK published not annually, but
periodical reports.
Yes, the register about the adverse events and reactions. In Italy, we don't have a public registry about this one, and so the information, to obtain information is complicated. So
it's not working well.
For example, I read the last report of competent authority, and our problems is related to the transport, but I don't know what is the problem in particular, but the transport. While in UK you can find the problem is particularly described.
Yeah, microbial contamination,
yes.
Loss of embryos, loss of
yes.
blah blah blah. Okay, this is a feeling that we had. And anyway, in the new blood tissue and cell regulation, that will be a regulation, not a directive, a regulation, we don't have adverse event and reaction anymore, but severe occurrences, adverse occurrences.
In
so
the new guide
it will come, still to come, but there is no the distinction that was not really easy between adverse events and reactions. So.
Great.
Okay, very last. we cannot say no to you. So,
Cristina, as you, we are traveling a lot, seeing a lot of labs all around Europe, and I'm really shocked, but in Italy, we have very severe directives, so our labs are really super filtered, super air quality, super instrumentation and control. Why? Because we always say Italy is not good, but believe me, when you go in other countries in Europe, even in the north, normally we expect this in the south, but also going in very north, the directives are applied in a completely different way. And I visited a lot of labs without changing, not even covering my shoes. And I stop here, not going more in detail. So I think that our labs are really, even in a too much control condition, with a lot of expenses, of course, and a lot of... This was my last comment.
very good, very positive comment. So I think that with this very positive comment, if you don't have anything else to add, we can close the session.
Thank you, everybody, for staying until now. We will meet here tomorrow at 8:45. Thank you very much.